شو دكاترة احكوا لنا عن بتشوفوا كتير أنا neurologist so بتشوفوا كتير you know weakness و neurology symptoms ولا لا؟ قبل ما رامي يظبط
دكتور احنا في عندنا اخصائي نيورولوجي هون جديد بلش من سنه تقريبا.
اوكي
نشوف حالات بس قبل هيك يعني ما كنا كثير نشوف.
طب ممتاز. لأنه احنا هلا اليوم بدنا نحكي عن myasthenia gravis و جيليان بيري سيندروم. شفتوا حالات قبل هيك؟
هاي عندنا حاله في الاي سي يو.
اوكي ممتاز. اي وحده جيليان بيري او myasthenia؟
هي اجت از كيس اوف ريفيرد از كيس اوف مايستينيا بس طلعت جوليان بيري المريض انكيوبيتد واكسبيتد اليوم.
اوكي جود. وكيف عالجتوها؟
بلازمافيريسيس.
Oh nice. Okay great. Who does plasmapheresis بنابلس؟
بس في النجاح فيه عشان هيك هم بمعظمهم بنشوف هدول المرضى جوليان بيري والمايستينيا بنشوفهم لانه بلازمافيريسيس بشمال الضفه فقط في النجاح.
اوكي بيرفكت ممتاز. طب كويس و مش مشينا على اي شيء ثاني، اي immunotherapy ثاني ولا بس plasmapheresis هلا؟
هو التشخيص النيورولوجيست عندنا انه acute onset CIDP مش جوليان بيري بالتحديد يعني.
اوكي.
فهو اصلا لما اجى كان يعني برايفت ديagnosis كان مايستينيا فاخذ ستيرويد وعمل سيشن بلازما بس ثاني يوم انعمل له نيرف كوندكشن وبين في النيرف كوندكشن انه يعني جوز تيبيكال with يعني demyelination. ف واعتبر الدكتور تشخيصه acute onset CIDP يعني اول مره نسمع فيه يعني.
اوكي
ستيرويد وكملنا على بلازمافيريسيس.
اوكي جود. وقد ايه عمره المريض؟
عمر المريض 53 سنه.
اوكي جود. نايس. شو بدنا نحكي عنه؟ وفي اي في اي جي بالضفه؟
في المستشفيات الحكوميه موجود. اخذ المريض اي في اي جي والسيمبتومز من شهرين بس اخذ اي في اي جي وما تحسن. له تقريبا شهر ونص ما اخذ.
اوكي good. اوكي gotcha. Yeah, so this is important. حنحكي عنها كمان شوي. The time most of the GBS اللي هو acute inflammatory demyelinating polyneuropathy they peak within 2 weeks وبعدين they usually بتخلص من النادير من ال you know من ال يعني the most severe within 4 weeks. It's very rare to last يعني تكون المريض بأسوأ حالاته بعد 4 weeks من التشخيص أو من onset of symptoms. So that's why you should consider then CIDP. ال differences ما راح نحكي على CIDP. I didn't know صراحة إنه بدكم إياها بس ال differences مش بس يعني بالاسم أو بالduration. The difference is also بالpathogenesis as well والpathophysiology. We don't know exactly CIDP ليش هالقد بيختلف من الجي بي اس بس we think that ال AIDP أو الجي بي which is you know part of the GBS اللي هو احنا بيكون في عندنا صار نوع من الموليكولر mimicry where we have you know probably 75% of the cases we have an infection preceding وبيصير في عندنا antibodies that identify the same antigens من هذا الانفكشن على النيرف سيلز والاكسونز. واذا كانت AIDP which is acute inflammatory demyelinating polyneuropathy the antibodies they are usually على المyelin itself. Sometimes we have something called AMAN which is axonal or acute motor axonal polyneuropathy which usually على nodes of Ranvier you know اللي هم between the Schwann cells بيصير فينا الانتيبوديز. CIDP is a little bit different. It's also على nodes of Ranvier وبرضه على sometimes على axons وعلى المyelin as well. But it's more of a more complicated pathophysiology اللي بتصير في عنا. The treatment شوي بيختلفوا as well. CIDP as well, you do steroids with it. With AIDP or GBS, we don't do steroids. There's no role for steroids at all with GBS. And some people say it actually it might worsen it as well with GBS the steroids. But with CIDP it does. We treat it, and as well as more aggressive immunotherapy. So sometimes mycophenolate mofetil, Cellcept, Imuran or azathioprine, rituximab, which is anti CD20. We can use with that as well. So هذا أكثر مع CIDP. Okay.
Khalil, I'm still facing the problem with login. I'm not sure. Can't even myself log in as a host.
Can you share it yourself, Rami?
No. في problem بالlogin. I don't know. I can't log in the PAMA account. I think the only option إنه يعني either you give the lecture without sharing slides إنه
that's fine.
أو إنه بنأجلها لوقت ثاني إذا ما بتحب.
No, I'm fine. Whatever you guys want. دكاترة إيش بتحبوا؟ أنا عادي ببعث لكم my slides وهلا بنقدر بس إنه نحكي. شو رأيكم؟ اوكي وإنه ببعث لرامي السلايدز وهو هو ببعث لكم إياهم.
سوري خليل مش عارف شو المشكلة إن شاء الله فكرة.
ما في أي مشكلة. ما في.
إسلام.
اوكي great. So فكرت إنه إحنا أول شيء صباح الخير للي إجوا اللي هلا إجوا. أنا دكتور خليل الحصري. أنا استشاري أمراض دماغ وأعصاب neurologist ومسوي sub specialty في الابيلابسي actually والEEG. أنا هلا assistant professor بجونز هوبكنز University. ففكرت إنه نحكي شوي على neuromuscular medicine just to go over basics وكيف how to approach the patients وكيف بنشخص وشو التريتمنت وشو يعني what to focus بالhistory والphysical exam. I think إنه أول إشي إنه لازم نشوف بالمريض إنه لما نشوف أي مريض إجانا بأي weakness it's try to localize it because that's the whole point of neurology is to try to localize where the lesion is. And usually we divide them into two big groups. We have the CNS, the central nervous system, and we have the peripheral nervous system. We usually, the central nervous system, we have the cortex, but then we have the subcortex, اللي هي involving the corona radiata, internal capsule, basal ganglia, and the thalami. We also have the brainstem, then the cerebellum, and then the spinal cord as well. All of these 5 sections, they constitute the central nervous system. بعدين بيجي عندنا the peripheral nervous system, which starts with the anterior horn cells, which are the alpha motor neuron. بعدين هدول بعطونا الroots, والroots هدول they go together وبعطونا the plexus, which is the brachial plexus and the lumbosacral plexus. وبعد هيك بعطونا nerves, the peripheral nerves, and then the peripheral nerves they will synapse the neuromuscular junction, and then they will end up on the muscles. So هذا هو 11 system that we have the neuroanatomical localization. We can differentiate exactly. It depends on what's the complaint and what's the physical exam. By the end of the history and the physical exam, you should be able to localize where is the lesion at least, or at least a couple of them. من ال11. So it's always a good exercise to write always هدول ال11 كل ما نشوف أول مريض, especially early on in your career, وتبلش تصير to eliminate إيش اللي هي مثلا ممكن ال signs and symptoms to fit أو بهذا المريض أو لا. Whenever a patient comes with a weakness, the first question is, does it localize to the CNS or to the peripheral nervous system, right? And we go more with the central nervous system. إذا كان في عندنا brisk reflexes, for example, if we have increased tone, if we have sensory motor on 2 limbs on the same side, so it's more of a hemibody, right? And if we have weakness of the anti-gravity muscles. The anti-gravity muscles بجسم الإنسان, they are the extensors of the upper extremities and the flexors of the lower extremities. عشان هيك مرضى الستروكس, if you pay attention to them, it's usually the extensors of the upper extremities that they are weak, right? So it's usually the deltoids is weak, triceps is weaker than the biceps, and the wrist extension is weak. On the contrary, the lower extremity, it's usually hip flexion, dorsiflexion, right, rather than plantar flexion, and knee flexion rather than knee extension. And that's why مرضى stroke, they have flexed like this بالupper arm, or they have this circumduction gait, because we have a preferential weakness by these anti-gravity muscles. وهذا it stemmed from the lateral corticospinal tract. So it's more of an evolutionary phenomena that happened. So this is very important, is to focus on the anti-gravity muscles to try to find which pattern of weakness it is. So central nervous system, we said breast reflexes, increased tone, sensory motor on the same side, so both limbs on the same side, weakness of the extensors of the upper extremities, and then flexors of the lower extremities, right? Sometimes with the spinal cord, we will have something called the sensory level, of course, which is, we have a loss of sensation or hyposthesia in both the legs and the trunk, just below a certain sensory level as well. Other features that favor spinal cord localization, we're going to have decreased pinprick sensation on one side, وبعدين we have decreased proprioception and weakness on the other side, which is, we call it the Brown-Séquard syndrome, right? Now, going more with the peripheral localization, which is starting from the roots, the plexus, the nerves, and so on, usually most of them, they have pain. So pain as a limb pain is a very, very unusual, be a sensory, be more of a central. So مرضى strokes, usually they don't complain of a pain in the arm, right? So if you have pain in the arm, think more of a peripheral. If you have decreased reflexes in the arm or the leg, think more of a peripheral localization as well. And also think of if you have both weakness that involves, length dependent. So it starts more, in the feet, in the hands, more than, more proximal as well. Also think more of a peripheral as well. The next question is to figure out now, if we know it's a peripheral, to try to figure out, where on the peripheral. So again, embellish with anterior horn cells, and we go down the list. So again, anterior horn cells, then we go to the roots. بعد الروتس بيجي عندنا البلكسس، بعد البلكسس بيجي عندنا nerves، بعدين neuromuscular junction، وبعدين بيجي عندنا المسلز، right? So the anterior horn cells، مين بقدر يعطيني examples على ال anterior horn cells diseases or pathologies that we have? Any idea, guys? Yeah, exactly. Polio, absolutely. So polio is one for sure. What else? كمان ممكن يكون في عندنا anterior horn cells. So ALS, right? Amyotrophic lateral sclerosis as well. إذا شفتوا مرضى بالهيك, do they complain of any sensory symptoms هذول المرضى? Yeah, so usually لا, exactly. So this is very important. So anterior horn cells, usually it's only motor symptoms and signs, no sensory symptoms, right? And usually it's a subacute to acute. It's very rare to present with an anterior horn cell pathology that comes very acutely. And examples, as we said, polio, which is only lower motor neuron, ALS, which is a combination of both. We have also West Nile virus as well, lower motor neuron. In kids, we have SMA, spinal muscular atrophy, and also in older individuals, Kennedy's disease, which is spinal and bulbar muscular atrophy as well. Now, how about roots? Radiculopathy or roots, it could be either a monoradiculopathy, so only a single or a couple of roots, or it's a polyradiculopathy. And the single roots, it's usually the disc, right? So we have a cervical, or we have a lumbar, we have either a stenosis, or we have an intervertebral disc herniation. And it's usually both, it could be either motor or sensory, or it could be both, right? And the main feature of a radiculopathy is pain, right? Because it's a painful condition. And usually the sensory, it comes actually first, بعدين الموtor. So, you know, because it depends on the compression. So this is with the roots. So pain is very important. We have decreased reflexes if the reflex is involved in the root, and then it could be sensory, motor, or both, and painful, right? And etiology, most likely, it's either a disc, it's either spondylosis. Less common causes, you know, if you have like an osteomyelitis, a discitis, vertebral fracture, if you have like a metastases to the vertebral bone, وبعدين سوينا compression على roots, so it can cause that. So this is mostly with a monoradiculopathy, so a single root or two. It's usually a compressive pathology, right? However, if we have a polyradiculopathy, where, you know, we have multiple roots that they are involved, هون بيكون في عنا, it's usually not a compressive, but it's something else. So, for example, porphyria can give you that, diabetes can give you that, of course, AIDP or GBS, which we're going to talk about, all of that infiltrative as well. Lymphoma, for example, also other inflammations like lupus, you know, sorry, Sjogren's disease, sarcoidosis, and also other infections, Lyme, HIV, varicella zoster, and tuberculosis as well. So these are the radiculopathy. And usually a polyradiculopathy, it starts with this pain in the back, which we're going to talk about in a second. بعدين بيكون في عنا weakness and sensory symptoms, as well as decreased reflexes. Plexus, it's usually we have, you know, the two big plexi that we have, which is the brachial plexus, and we have the lumbosacral plexus. The key with it to identify a plexus pathology is that it's a multiple nerves are involved. It's usually unilateral, however, it can be bilateral, but it has to be asymmetric. Remember, it's the patchy. Whenever you have a plexus pathology, it's usually a patchy pathology, meaning that it affects, you know, a certain nerve here and another nerve there, and so on, plexus. So the weakness, it's a little bit, you know, haphazard, all over the place. It's usually a little bit more proximal than distal, but you get this painful, patchy pattern of weakness and sensory findings. And again, everything in weakness is about pattern recognition, and try to put everything together at the end of the exam, whether the شو المريض عنده نوع الويكنس اللي عنده اياها حتى نعرف وين اللوكاليزيشن وبعدين شو diagnosis, right? Examples of a plexus pathology, we have idiopathic brachial plexopathy, which is, we call it Parsonage-Turner syndrome. Usually هدول, it's usually younger patients. They come with this intense pain, be their shoulder or all the way down, radiating down. But then after the pain, you get the sensory loss and you get the weakness as well. It's an immune-mediated disease. We have also diabetic patients. So diabetic patients, they can come with an asymmetric lumbosacral radiculoplexopathy. So, you know, about a subacute onset of weakness and sensory loss that happens be diabetic patients. It's usually hip flexors, extensors as well, maybe some knee flexion and extension as well. Malignancy is an important cause for plexopathy. You know, either infiltration, if it was more of an infiltrative disease, like a carcinomatosis meningitis, lymphomatosis meningitis, or local, you know, from either a lung, you know, like a lung cancer going into the brachial plexus, or maybe some sort of a GI or a GU cancer going into the lumbosacral plexus. And also radiation. After radiation, you can get plexopathy as well, and we call it radiation plexopathy. So it's an important differential diagnosis as well. Now the nerves, let's go down to the nerves a little bit, which is either a mononeuropathy or a polyneuropathy, or it's a multiple, which is, we call it mononeuritis multiplex, right? And it usually, it depends on the nerves involved. If the nerve is a mixed, it's motor and sensory, you will get both motor and sensory. If the nerve is sensory, you will get only a sensory neuropathy. And it can be painful, and the reflexes are decreased. So here, the important thing with the nerves is that we have a sensory component with it. And that's why, in contrast to the neuromuscular junction, which is non-sensory symptoms, not painful, is usually symmetric. And, you know, the hallmark of it is what? Is myasthenia gravis, or the, you know, the most common disease. And we have always involvement of the cranial nerve. So ptosis, diplopia, ophthalmoplegia, and we have some breathing problem as well, you know, dyspnea, dysarthria as well, trouble talking, and the weakness in the extremity, which is usually proximal, fatigability, of course. And with Lambert-Eaton, we have a little bit of decreased reflexes, but usually with myasthenia gravis, the reflexes, they are preserved as well. So there's a good contrast between myasthenia gravis and between Guillain-Barré syndrome, right? Or between CIDP, which is what? Which is, you know, the reflexes, they are usually preserved in myasthenia gravis, no sensory symptoms in myasthenia gravis, and we have a fatigable weakness. On the contrary, with the CIDP or an AIDP, we have, it's a painful condition, usually we have prominent sensory symptoms, and we have decreased reflexes. So we have, you know, a good deal of differences. Now, finally, we reach into the muscle, which is the myopathy and the myositis. And again, no sensory symptoms. It's usually asymmetric. It's a proximal weakness. The myopathy is usually a systemic disease that affects the muscles everywhere. So that's why it's more of a symmetric and proximal. And the proximal, because the bulk of the muscles proximally, they have a higher bulk, so they will be affected more than the small muscles distally. And again, the reflexes, they're usually preserved until it's a very, very advanced disease and severe disease. And you will get the component, you know, the complaints of exercise intolerance, fatigue, muscle atrophy, weakness as well, and cramps, myalgia. You could have some myoglobinuria, right, in the urine if we have a breakdown of the muscle. So in the ER, we have sometimes acute presentations of all of these, right? And the acute presentation of motor neuron disease is usually acute flaccid paralysis, which is AFM. I'm not sure if you've seen cases. It's usually in kids, and it's associated with enterovirus disease. It started a few years ago. It's more of a every 2 years cyclical epidemic that we see here in the States. Paraneoplastic conditions can also affect motor neuron disease. Spinal roots, we have, of course, disc herniation, acute, you know, sensory neuron, which is paraneoplastic or pyridoxine toxicity. And then we talked about the plexus, the nerves, the neuromuscular junction, and the muscle as well. Okay, so let's go to Guillain-Barré syndrome. So we're going to talk about two of them, which is Guillain-Barré and then myasthenia. So Guillain-Barré syndrome, or GBS, is a common cause of acute or subacute flaccid paralysis. So, you know, so the hallmark presentation is that we have this symmetric weakness of the limbs that starts, you know, in the legs and then ascends up with decreased reflexes, right? However, remember that the clinical course, the severity of GBS, they are very, very variable. So not all of the patients, they present with this textbook presentation. On the contrary, most patients, they do not. It usually starts with the sensory symptoms, with, you know, with the paresthesia or numbness. It usually starts distally to have a symmetric pattern. I had a patient, I remember, during residency, who come in complaining of abnormal taste, actually. And have been like to multiple ERs over the past few days. وما حدا عرف له. بعدين إجا, بعدين also on the same time, he was like, you know what? كان هو roofer as well. فبقول لك إنه أنا صرت أتعب شوي وأنا إنه during my work as well. So he didn't complain of any way. It's mainly his taste that would bother him. We sure did. You just you check his reflexes. It was absent everywhere, and you know, we diagnosed him with the GBS, gave him IVIG, and he, you know, he recovered nicely. So the presentations, they can be very variable. So remember that. the incidence of Guillain-Barré syndrome, it's still a rare disease. It's not a common disease. You know, I think, you know, if you work بالنجاح or if you work, you know, في big centers, you will get a referral bias, of course. So you will see more patients, but usually it's about 1 in every 100,000 persons a year. And it's more common in men than women, but the ratio is like 3 to 2. And it usually is less frequent in children than adults. And the incidence increases with age. So, you know, older people, they are more susceptible to it. And as we were talking, the pathogenesis is, GBS is thought of an inflammatory post-infectious disorder. About 2/3 or 70% of the patients, they report a preceding respiratory or GI tract before GBS. So it's fairly common to have an infection, just a mild flu-like or GI, you know, about, you know, maybe a week before the onset of the symptoms, or even up to 2 weeks before the onset of the symptoms. In about 50%, you can specify it exactly. And, you know, the famous on the boards, it's usually Campylobacter jejuni, right? Campylobacter jejuni is responsible probably of the third of these infections. It depends on the country and the geographic. It's more common in Asia, in you know, be China or be Japan. They have a lot of Campylobacter jejuni induced Guillain-Barré syndrome, and it's usually associated with the worst outcome because it's more of an axonal pathology rather than a demyelinating, which is the AMAN type of GBS rather than the AIDP. Other pathogens, you know, CMV, Epstein-Barr virus, Mycoplasma pneumonia, Haemophilus influenza, hepatitis E, and influenza A virus. For COVID, there was a recent paper that showed actually still no association between GBS and COVID infection so far. So that's at least thankfully. So again, so we have here, we have a nice figure, which, you know, molecular mimicry with and the anti-ganglioside antibodies, they look the same. So that's why the antibodies against, you know, the infection, against the Campylobacter jejuni, they will start attacking the same anti-gangliosides antibodies, and they start attacking the Schwann cells in the peripheral nerves. And with the AMAN type, they attack more the nosotranvir, and we have a complement-mediated destruction as well. Okay, so let's talk about a little bit clinical presentation. So it usually evolves over days. So usually المريض يجيك within few days. ما راح يجي المريض بأول يوم. Very rarely مرضى بيجوا أول يوم. And usually it progresses within a couple of days. It could start with this pain in the back. So a lot of patients, they describe this pain in the back, which is like a radicular, and it's from the inflammation, the onset of the inflammation. Just a little bit of a pain. مش كتير severe صراحة. بس and then after that, it starts with the numbness. So the numbness that usually starts in the feet, and then it goes up, as well as the weakness as well. And the weakness at first, it will be a little bit, you know, not very prominent, but then over days, it will snowball. Approximately 50% of patients, they achieve the maximal weakness within 2 weeks, and 80% by 3 weeks, and 90% by 4 weeks. If the المريض is still deteriorating after 4 weeks, this is not GBS. The weakness, it can be more proximal than distal, okay? So it's not usual, يعني, I know it's classically the ascending paralysis, but because it's a radiculoplexopathy as well. So sometimes the proximals, they will be more involved than the distal. And as we said, the neuropathic pain is fairly common, about 2/3 of patients, and it's usually lower back and thighs, because, you know, all of the big nerves, they are there and they are inflamed, on fire. So on exam, usually the sensory examination may be normal, or it may be show just minimal deficiencies. So if you examine all the patients within 4 weeks with the reflexes almost 100% of patients, they should have lower, decreased reflexes. So either hyporeflexia or areflexia. However, remember is that it evolves, the disease evolves. So on presentation, some patients, they might have preserved reflexes, but usually they will lose them in the next day or two or week. I have to try to always think of the diseases as a spectrum. So not everything has to be present on presentation. The best diagnostic tool for a neurologist is re-examination. And about 50% of patients, they have facial weakness. So this is also very common. And also we could have weakness in other cranial nerves. So, you know, pupillary changes, some ptosis, some eye movements abnormalities as well. And again, about 30% they have respiratory failure, and it's usually from phrenic nerve involvement, and they end up intubated, mechanical ventilation. The other thing that's common with the Guillain-Barré syndrome is autonomic involvement. So they would have, you know, labile blood pressure, they could have tachycardia, bradycardia, gastric hypomotility, you know, also constipation, urinary retention. So all of these you need to pay attention to. This is a nice graph that tells you, you know, the difference between the course of the GBS. So usually we will have, you know, a few days of prodromal symptoms, and then the weakness and the symptoms and the sensory loss, you know, starts going down. It reaches the peak or the nadir within approximately 2 to 4 weeks, and then you have a recovery after 4 weeks that takes up to several months sometimes. Okay. Do you guys have any questions? Okay, perfect. We have, so not all of GBS, they are, again, is the same. We usually have, you know, approximately 5 subtypes. I'm not sure how advanced this is, but 5 subtypes of GBS. The classic one is the AIDP, which is acute inflammatory demyelinating polyneuropathy that الكلنا بنعرفه. The other type is it's AMAN, which is acute motor axonal neuropathy. It's a pure motor GBS, does not affect the sensory, and the cranial nerve is usually, they're usually rarely affected. We have something called acute motor sensory axonal neuropathy, which is AMSAN as well. And there's a famous one, which is called Miller-Fisher syndrome. Miller-Fisher syndrome, it usually comes with ataxia, ophthalmoplegia, and areflexia. And in AIDP, the antibodies, you know, testing is not very important because it's somewhat heterotopic and variable. However, in the AMAN is important because it's a GM1A antibodies and the GM1B, and then with the Miller-Fisher syndrome, it's a GQ1B antibody. That's the, you know, that's the culprit here. So investigations, what we should do للمرضى, the first thing is CSF studies. So CSF, so the hallmark again is this albumin cytological dissociation. So we'll have high protein, we'll have normal cells, okay? However, remember, it should not be present on diagnosis. Sometimes if you do it too early, let's say the inflammation is not there yet. So that's why the protein might be normal early on, okay? Approximately 80% of patients, they will have a high protein if you tap them within the first week after the onset of the symptoms. If you do it on the first day, on the first 2 days, sometimes it can be falsely negative and it can be, you know, normal, but then the inflammation will kick in and it will appear a couple of days later. Usually the cells, you know, classically we say that if you have CSF pleocytosis أكتر من 50, then this is not Guillain-Barré syndrome. So look for other diagnoses if you have more than 50 cells. You know, up to 5, 10 is okay, but usually up to more than that, you know, this is like a red flag to look for anything else, to look for infectious, to look for, you know, lymphomas. HIV can give you that as well. So just look for it. this is a nice slide that I have that, we have a diagnostic criteria for Guillain-Barré syndrome. So remember, progressive weakness in the legs and arms, areflexia or hyporeflexia, progression of the symptoms lasting only up to 4 weeks. It's usually symmetric, in most of the time, approximately 90% of the cases. The sensory symptoms and signs, if present, they are usually less impressive than the weakness. Pure sensory GBS is extremely rare and is also a red flag. Autonomic dysfunction is very common. Pain is common as well. We said بالباك وبالlegs. Absence of fever, and you could, we have the high protein normal cells in the CSF. And if you want to do an MRI as well on the back, you could have enhancement of the peripheral nerve roots and the coda equina. But again, you don't need it. So you only need, the CSF that we usually do on every patient. Now, nerve conduction test and EMG, again, it can be normal up to 1 or 2 weeks. Because remember, with the nerve conduction test, the changes that we see, the demyelinating, it takes time to kick in. So you shouldn't do it early in the course of the disease. You can only do it just to, if you are suspecting another diagnosis. And it depends on the subtype. If it was an AIDP, then you will see demyelinating features, prolonged latency, reduced nerve conduction velocity. You will see temporal dispersion and conduction block. If it was axonal, the AMAN or the AMSAN, then you will see more with decreased amplitude and more axonal type findings. Antibodies, serology, it's usually limited utility in GBS, except be Miller-Fisher or except be AMAN, which they have a very specific antibodies. And then you could do also MRI lumbosacral with contrast, but again, it's not routinely done as well. And you see the enhancement. Differential diagnosis is fairly, extensive, but I would say mostly is infectious, mostly also, sometimes that's it mainly. It's usually a straightforward presentations most of the time. Okay, any questions before we go to management? No? Oh, I can't hear you guys.
Yes.
Okay, perfect. So the treatment is usually we start with supportive. It's usually both a supportive care and immunotherapy, okay? And the treatment, we have 2 treatments that they are equally effective. We have either IVIG or plasmapheresis. And IVIG, we usually, the dose is 2 grams per kilograms over 2 to 5 days. And the plasmapheresis is usually 5 sessions of plasmapheresis. Sometimes we extend it up to 7 sessions. Again, there's no role of steroids in Guillain-Barré syndrome. And the prognosis is actually, it's decently good. Almost about 80 to 90% of patients, they make recovery with only minimal deficits. So it's not that bad. It depends, if you have demyelinating, it's even better than the axonal type of Guillain-Barré syndrome. So that's mainly it, and you just have to support it. Now we have something called refractory GBS, which I think is a little bit, sometimes they don't respond with the first session, so we have to do more and more. But that's it. So hopefully this patient that you guys have improves with time with plasmapheresis. Plasmapheresis tends to work a little bit faster than IVIG. However, it has a little bit more, it's more invasive. You need a line, you need like a Quinton line or a dialysis catheter to do. It's associated with sometimes, a pneumothorax or something like that. IVIG, on the other hand, it's expensive, and it's a volume overload, so it's a lot of volume. So if patient has heart failure or any, contraindication to it, it's a hypercoagulable. So we had patients who developed PE and DVTs after IVIG. It can give you also chemical meningitis or aseptic meningitis with headaches and fever as well. So you just have to weigh the pros and cons for either of them. They're probably equally effective. I would say plasmapheresis is faster to act, and perhaps you could use it in more severe cases. And the reason for that also, sometimes we do sequential, and it's always best, you know, to start with plasmapheresis بعدين تعطي ال IVIG, because otherwise if you give IVIG بعدين سويت ال plasmapheresis, you're gonna wash out, you're gonna remove all of the IVIG that you gave, you know, within a week or two. So that's the issue. Okay, any questions, guys? Okay, so let's talk about myasthenia gravis now. Myasthenia gravis, so it's an autoimmune disease. It affects the neuromuscular junction, and it causes fatigable ocular, limb, and bulbar weakness as well. The prevalence is about 1 in 5,000, and it affects all ages, and it peaks in women and older men. So it's usually younger than 40 is much more common in women, about 7 to 3. So, however, in older, men are more common over 50. So less than 50 women, more than 50 is usually men. It's very rare in pediatrics, and it's one of the best understood diseases in terms of pathogenesis and pathology. And you know, it's kind of like the benchmark for autoimmune neurological diseases. It's very simple. We have an antibody-mediated T-cell dependent attack on the postsynaptic membrane. So these postsynaptic membrane, they attack the acetylcholine receptor, and this will prevent the transmission of across the neuromuscular junction. The main antibody for this is the acetylcholine receptor antibody. However, we have other antibodies as well, such as MuSK, such as Titin antibodies, and LPR4 antibodies as well. And the destruction is both T-cell, and also it's a complement mediated as well, the destruction that happens. Now, the clinical presentation, the classic is a fluctuating, fatigable weakness of muscle groups that worsen with exercise, improves with rest. Ptosis is very common, as well as diplopia, binocular diplopia. They are the most common presenting symptoms. In some patients, we get some more bulbar weakness. You will get flaccid dysarthria, you will get dysphagia, jaw closure weakness, facial weakness, weak smile. You'll get also nasal speech after prolonged speaking. Some patients that they describe, you know, they can't to drink from a straw. They can't smile. They have, you know, food coming out of their mouth. So all of these, it means that, you know, we have a bulbar weakness happening. Neck flexion is usually more affected than neck extension, and weakness of the limb is usually proximal more than distal. However, the wrist extensions, they can be involved, and the triceps as well. For some reason, triceps is almost involved in myasthenia gravis. The most important thing is that no sensory symptoms, no pain as well. So these are two different, and it's not an ascending paralysis. On the contrary, you know, it has a very prominent, you know, bulbar and eye move, you know, either ocular or ptosis as well. This is with the acetylcholine receptor. We have a certain patients, we call them MuSK antibodies. They have a little bit atypical clinical course, and they come mainly with neck extensor weakness, shoulder weakness, and more of a breathing and respiratory. So they come more with a shoulder, breathing, and bulbar symptoms. And they're usually in women as well. And they responded poorly to the treatment of myasthenia, which is the pyridostigmine. Now we have a test that we used to do. It's always fun to do in clinic with the medical students, which is the ICE-PAC test. So the ICE-PAC test is a simple bedside test, which is mainly for the ptosis. So if you have a ptosis, what you do is put an ice على جفن المريض, and then wait for at least 5 minutes, and then you will have improvement of the ptosis for at least about 2 millimeters, and it's considered a positive test, and it's fairly sensitive for myasthenia gravis. Serology by myasthenia is very important. On the contrary, as we said, GBS is not very important, and myasthenia is very important. And it's one of the first diagnostic steps that you should do if you suspect myasthenia gravis, is to send the antibodies. And you can find them in about 80% of patients with generalized myasthenia, which are the positive acetylcholine receptor antibodies. These are the most common in myasthenia. We can usually divide myasthenia into generalized and into ocular, and then the generalized into either early onset, أقل من 50, late onset, more than 50. And most commonly, the antibody is in generalized myasthenia is acetylcholine receptor antibodies. Others, including, we said the muscle specific kinase, and we have very rarely something called LPR4 antibodies as well. Nerve conduction test, we can do the repetitive nerve stimulation. They are, very more sensitive in generalized than in ocular myasthenia as well. And we can have the CMAP, it will decrease, we have a gradual decline. Every patient with a generalized myasthenia should get a CT chest to look for thymoma or thymic hyperplasia. So you have to do that, But this is, can be done in the outpatient. It's not emergent, of course. Now, how do we treat myasthenia gravis? So it all depends on the severity of the presentation, okay? So the gold standard, or the cornerstone of the treatment is pyridostigmine. So mestinon or pyridostigmine is the most commonly used, and it's an acetylcholine esterase inhibitor. So it inhibits the enzyme that breaks down acetylcholine. So that's why the acetylcholine stays longer in the synapse. So you'll have a better transmission. You can use it only without immunotherapy if you have an ocular myasthenia or if you have a very mild case of a generalized myasthenia. But usually the treatment is pyridostigmine plus immunotherapy. Pyridostigmine, it works within 3 to 40 minutes, so it's fast. However, it lasts only for 3 to 4 hours. It's usually a 3 times a day medication, sometimes up to 4 times a day medication. One common mistake is that some patients, they take it before going to bed. You shouldn't, because then, what's the point? It's a very symptomatic treatment. So take it 3 to 4 times a day during waking, and not before going to bed. Common side effects is more of the cholinergic, so abdominal cramps, diarrhea, excessive lacrimation. So all of these cholinergic excess symptoms. Now, however, in most of the cases, we usually do immunotherapy. And the most common immunotherapy, of course, is corticosteroids. However, the corticosteroids, it should be also only used for a short period of time, right? Because of the side effects, of course. And we should always think of a steroid-sparing agent to be with the corticosteroids. One caveat is that, remember, high doses of corticosteroids can make myasthenia worse, and you can induce the patient into a myasthenia crisis. So always in the clinic, always start with a low dose of corticosteroids, 5 milligram per day of prednisone. وبعدين gradually increase it every week up to reach most patients about 40 to 80 milligram per day of prednisone, and they will have a good response on that. And then once you have a good response, and once the steroid sparing agent has kicked in, you should start tapering off the prednisone as well. Okay, so the steroid sparing agents that we use, we have the two most common that we use. They are mycophenolate mofetil, which is Cellcept, and the other one is Imuran or azathioprine. Do you guys have you guys used these two medications? Like, I can barely hear you. Sorry. What's the second one? Oh, okay. Okay, so how about Imuron, Imurano, mycophenolate, and any steroid-sparing agents? No? Okay.
Once we use the
Okay. Yeah, I mean, they are fairly, they are used for rheumatology, you know, for everyone. So, I mean, I think they should be more available. So the mycophenolate mofetil is an inhibitor of the monophosphate dehydrogenases. So it inhibits the cell-mediated immune response and antibody formation. And they're usually 2 grams to 3 grams per day. And it takes about 2 months to kick in. So, you know, it's a very slow action to kick in. And the Imuran or the azathioprine, it's a nucleotide synthesis inhibitor and blocking the T lymphocyte proliferation as well. Other medications, we can use rituximab, which is anti-CD20 antibodies, which is an infusion. There's a new one, it's called eculizumab, and it's a complement inhibitor. And it can be used for very, very refractory or severe myasthenia gravis. Finally, so 5 years ago, we only did thymectomy for patients with thymoma or thymic hyperplasia. However, there's a recent study 2 years ago in New England Journal of Medicine that showed that thymectomy is actually indicated for every patient with a positive acetylcholine receptor antibody between the ages of 18 to 65. So thymectomy is now one of the treatments for, even with a normal thymus tissue, for myasthenia gravis. Okay. Now let's talk a little bit about myasthenia crisis. Sometimes the patients, they come with an acute exacerbation of their weakness, and it's mainly the bulbar and the respiratory that gives you the most trouble. And sometimes, you know, we can't identify a trigger for the myasthenia crisis, but sometimes we do. So for example, surgery, pregnancy and postpartum, heat, stress, viral infection, so they have a flu, and also medications. As you all know, there's an extensive list of medications that can worsen myasthenia gravis, going from antibiotics, you know, aminoglycosides, fluoroquinolones, tetracyclines, penicillins, you name it. Magnesium can make it worse. Botulinum toxin, interferon alpha, you know, beta blockers, quinidine. You know, it's a very extensive list, honestly. And if you go, you know, if you Google it, you can have 200 medications. The important thing before prescribing them is to look how stable the patient is and what's the risks versus benefits, right? I mean, if the patient is stable and he needs the antibiotics, then you just need to give him. I mean, what are you going to do, right? But there's always this risk of exacerbation. And usually most of these patients, they end up being admitted, they end up in the ICU, and you know, intubated as well. And the treatment is either IVIG or plasmapheresis. We tend to stop their mestinon during the myasthenia crisis. And the reason for that is they usually, you know, they can't swallow. So that's number one. And number two is it can give you a lot of secretions that can mess up with, with the intubation and stuff. And sometimes they can present with a cholinergic crisis, which you have an excess of acetylcholine, and it can give you weakness as well. But usually it's not the case. Sometimes if the myasthenia crisis did not improve with IVIG or plasmapheresis, we can give, we can give steroids, We can use also, you know, rituximab or other more aggressive immunotherapy as well. And that's it for me. Do you guys have any questions?
I have a question. I have a case.
Yes, I can. Honestly, I can't hear you. If you can come closer. Sorry.
So we have a patient. He was admitted to our hospital 1 month ago. He was diagnosed with myasthenia gravis 3 years ago. Acetylcholine receptor antibodies was positive.
Okay.
He had thymoma, so he underwent thymectomy at that time, and then he continued on pyridostigmine. But
Okay.
every year he is admitted, or he is admitted to the hospital for 1 or 2 sessions of plasmapheresis because he usually has a general weakness and a bulbar palsy.
Yeah.
So my question is, do we have a myasthenia gravis symptoms even after thymectomy?
Oh yeah, we do, of course. Yeah, yeah. I mean, so thymectomy is good, but I mean, it's not. So the study was thymectomy plus medical therapy versus medical therapy alone, and medical therapy included both pyridostigmine and immunotherapy. So not, I mean, very rarely the patients they completely have resolution of their myasthenia. No, it's just it helps with it. So this patient needs to be on immunotherapy. ليش مش على immunotherapy هذا المريض؟
Just على pyridostigmine وعلى prednisone 5 milligram.
Oh, so this is very low dose, prednisone 5 milligram. I mean, this patient also, what he needs is he needs a steroid sparing agent. So either Imuran or mycophenolate mofetil, which is Celsep. And then this way you will prevent the readmission every year with myasthenia crisis. I mean, clearly the 5 milligram is very low for him. Does he have any weakness هلا يعني outside the crisis?
After plasmapheresis you can improve the patient. بس أنا my question is إنه هلا إحنا عاملين thymectomy يعني ما في source of antibodies.
Okay. Oh, بس ما هو say that again.
يعني هلا في عنا إحنا thymectomy إحنا البيشنتس underwent. طب فيش إحنا antibodies يعني why patients عنده في general weakness myasthenia gravis symptoms.
Oh no, of course عنده antibodies. No, أكيد. No, so the thymus is not the only source of antibodies. I mean, the thymus, what happens is the maturation of the antibodies occurred in the thymus, right? وبعدين, but usually the antibodies, you know, they are produced بالbone marrow, and it helps. I mean, it's not, no. Of course عنده antibodies المريض for sure. with disease ما راح من مرة. So it only helps. It doesn't cure, unfortunately. Yeah, so this patient has to be on immunotherapy, you know, either Imuran, you know, Celsep, you name it, higher dose of prednisone. Oh, but then another thing I forgot to mention, always whenever you prescribe prednisone, make sure to prescribe, you know, all of the prophylactic stuff. So calcium, vitamin D, you know, to counsel about osteoporosis, higher risk of infections. If you are on a long time, you should also give the prophylaxis for pneumocystic jejuni or pneumocystic carini, the PCP or the PJP infection with Bactrim as well. These are mainly the two big things with the prednisone.
Okay, thank you.
Yeah, thank you.
Thank you.
Thank you.
Thanks, guys.